You're welcome once again to another episode of Reproductive Health, the Reproductive Health segment of Today on STV. Thank you very much for the SMSs, for the emails. They've been wonderful. Well, today's topic, I'm going to be responding to one of the mails I got. I'm going to be taking you through the lab procedure in assisted reproduction. Because some people still believe that there's some things that happen in assisted reproduction that they cannot still explain. And it's even as ridiculous as some believe that we keep babies in a test tube or in a bottle. And I even heard some people saying that they have to import the bottle or all kind of stuff. But really and truly, that's not the real thing that happens in assisted reproduction. So I'm going to be taking you through what happens in the laboratory in assisted reproduction. And we said the aim of this program is to demystify infertility and the treatment of infertility. Now, for any method to be called assisted reproduction, there are three parameters that it must have. The first of which is what we call sperm preparation. That must be a way to prepare the sperm, okay, that we're going to use for the treatment. Because it's like the raw material, we need to process it. And there must be some drugs that will be given to make the woman produce more than one egg, what we call superovulation. And then there must be a way of bringing the gametes, that the egg and the sperm together. Now, these three steps depends on how complex they are. We have three different prototypes. The most basic we call intrauterine insemination or IUI. The second we call in vitro fertilization or IVF. And the third we call ICSI, and all kinds of things that involve around, including laser hatching, that we need to sort of manipulate the gametes. So for any laboratory or any IVF center or any assisted reproduction center, the team consists of not only doctors who you always see and the nurses who you are familiar with, but there is an important group of people we call embryologists as well. The embryologists are people who handle sperm and eggs, and they ensure best environment for your embryos. Now, the funny thing is that embryos are thought to be able to smell, and therefore the environment in the laboratory is so important. You cannot have anything pungent, and that's why we say when you're coming for to bring out the eggs, or you're coming for us to replace the eggs, the embryos, that you don't use perfume or anything that is pungent smelling. So we try to keep smell out of, because these embryos are they're like human beings in the cellular form, and therefore they're very delicate. Now, let's start from when we have removed. We give patients drugs for them to be able to make more than one egg. Then we remove these eggs from their ovaries. It's not done surgically, so we don't cut anybody. There are some fine probes that we can use to the vagina. We can remove the eggs from the vagina, and it takes about 20 minutes, 20 minutes. You rest for another 1 hour, you're ready to go. Now, it is when we have removed these eggs that the embryologist starts to work. Now, they put these eggs in what we call culture media. The whole essence is that we don't want the eggs. The eggs must never know that they've left the body, because immediately they know they've left the body, they die or they go into shock. Just like we human beings, we can go into shock. They go into shock and then they never come back because they're proteinous tissues. So we allow once we've collected the eggs, we put them in the culture media, and we allow this to rest for about 4-6 hours before we do the insemination. Now, this insemination we do, that's bringing the sperm and the eggs together, it depends on the sperm count. If the sperm count is good, then we just mix the egg and the sperm together. That was what made this to be called test tube babies, because initially the mixing together was done in a test tube, bringing the sperm and the eggs together. That is when we're talking about the IVF or in vitro fertilization. So they bring the eggs and the sperm together. But this can only be done when the sperm count is good. So if the sperm count is good, all we just do is bring the sperm and the eggs together. The main work is that they must never think that they've left the body. So the temperature must be the body temperature, the pH must be the body pH. And then that happens, then once we mix them together, we put in the incubator. I'm going to show you some of the pictures of some of the incubator when we talk about the incubator. What does it look like? But if the sperm count is not good, then we use what we call intracytoplasmic sperm injection, or what ICSI, or what the patients call ICSI, we call it ICSI. Then we use the ICSI to fertilize the egg when the sperm count is not good. And this is the only thing that we know that can handle bad sperm. Okay, sometimes we might have to, when the man has azoospermia, then there's no sperm at all. We might have to go to the testes to bring out the sperm cells with what we call TESA, 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 testicular sperm aspiration. Now, when we bring the sperm and the eggs together, we're checking on them to see whether there is any evidence of fertilization. This we usually do between 12 to 16 hours to see whether any fertilization has taken place. The way we see that fertilization has taken place is when the two cells have come together and they form some cells that shows evidence of fertilization. Now you can easily see in the laboratory. Now, the moment this fertilization has taken place, the gametes now start to divide. By day 2, we need to have, if everything has gone well, about 2 to 4 cell stage. Some people transfer the 2 stage where you have about 4 cell stage. They transfer here, but some wait until the 3rd day. By day 3, if everything has gone well, you should have about 8 cell stage. Okay, so some people will transfer at day 3. They will have at least a 8 cell stage. Now, some will wait to have what we call blastocyst, which is the more advanced form of embryo, which is now it's not everybody who can have blastocyst, really and truly. I think we must say this now, because if you don't have enough embryos, then it's not very sensible to want you to wait to blastocyst, because sometimes if the number and the quality of the embryos is not good enough, you might not have anything to transfer on day 5 because none of the embryos might survive. So usually there are people who we do blastocyst transfer for. Those are people in which, one, they must have adequate number. What we do in my center is that you must have, on day 3, you must have at least 5 good embryos before we can contemplate going to blastocyst stage. Okay. Now, after depends on whether you're transferring on day 2, day 3, or day 5, the number of embryos transferred also is another issue that we need to look at. Now, the transfer process is a very easy process, painless. We don't use any form of anesthesia at all. It's just stealing it to put back the embryos back into you. And the number that is transferred is usually age dependent. The younger people will have less embryos than the older people, because the likelihood of they achieving pregnancy and even achieving multiple pregnancy is higher in the younger people. So we tend to replace less embryos for the younger people and more embryos for the older people. Yeah, I know in some places now, in some countries now, they do single embryo transfer. Yeah, most centers in Nigeria still don't do that. We transfer 2 or 3 embryos depending on the age. Now, the other things that we do is what we call assisted hatching. Now, when you're doing assisted hatching, usually you're doing a day 3 transfer. We do assisted hatching in my center. There are indications for assisted hatching anyway, because usually for people when the woman is above 37, or you can see that there's thickening of the covering of the egg, the new embryo on the microscope, then you might need to do assisted hatching. And some people also will say that if you're transferring frozen embryos, that it's good to do assisted hatching. Now, there are different ways of doing assisted hatching. Some use some needles and so on. But what we use in my center is the laser assisted hatching system, which is a very easy technique to do. So assisted hatching is one thing that can be done. And also the last thing I want to mention about is this embryo freezing. Now, it's possible to freeze embryos. If you have more than enough that is necessary, then we can freeze embryos, and this can be frozen for as long as you like. I know in some countries there are rules, maybe 2 years, maybe 5 years, maybe 10 years. Of course, we can freeze this as much for as long as you like, of course. But one thing I must also say is that you can only freeze good embryos, because if the embryos are not top grade, if you freeze them, because like anything you freeze, you expect some depreciation in the quality, then you're not going to get anything from it. But like I said, it's possible now to freeze excess embryos so that we don't need to throw away embryos, especially when they're good. And this you can now replace later on. And you can now have it also possible to have babies from frozen embryo transfer here, even in Nigeria. Yeah, so I've just attempted to take you through all the gamut of what happens in the laboratory in a nutshell. And I expect to have some responses from you on this. If something is not clear, I'll be more than happy to explain more. Thank you very much for listening. See you next week.